The last thing I want to do now is to show you my preferred technique for thoracic paravertebral blockade in the patients who have a little bit more, they're a little bit more cuddly, let's say. So I've got the probe placed in this orientation. I'm just going to show you a sequence of how you might want to look for the paravertebral space with a transverse probe arrangement. So there's a spinous process, sorry Laura, thank you. Spinous process right in the center of the screen. You can see the tip of the spinous process, and as I slide laterally, you can see that coming around, and we're going to start to visualize the lamina over here, and then you come to a tip of a transverse process. So I'm now in the transverse orientation. I've got a beautiful transverse process there, and as if by magic, I've come straight into the paravertebral space. That was way too easy, so let's not do that. I'm just going to play that. So this is what tends to happen. You place the probe transversely in the back, and you see something that looks kind of like this. You see some muscle. You see a bright white line with a high acoustic impedance and nothing very much below it, and then you see a bit of pleura. This is what really happens. So that's assuming the ribs were traveling in a purely transverse direction, which they're not. So the first thing I do when I place the probe on the back is I say, right, I want to find a solid white line, which is the rib, and I want to scan along its whole long axis. So I'm going to try and work out how to find it. So there we are. So I'm now scanning along the whole of a rib, and I know it's a rib because I really can't see very much below it. And you can see the orientation of my probe in relation to Dante's body. So I'm scanning along the length of the rib. And I'm now going to slide that towards the midline, trying to stay on it the whole time. And at this point, I've now come to a point here where I'm at the costo-transverse junction. The arrow is, in fact, perfectly placed there. So you've got a rib meeting the transverse process. And now you've got a choice. I can go up or down, but I'm going to go down. I'm going to drop into an intercostal space. So here we go. I go back up, rib meeting transverse process, or drop down. And there's pleura. And now I'm going to scan laterally. You can see now I'm now scanning along the length of the pleura. So I'm positioned here. This is actually a perfect position for how one might do a transverse in-plane access to the paravertebral space. And that is about as good as a picture as you'll get. Let me just get a nice image there. If you just freeze that for me there, please. Perfect. So you've got a beautiful view here of the pleura. You can see the pleura as we get towards the midline, it dives down. You've got the erector spinae complex sitting directly on top of the transverse process, and you're getting a suggestion here of the internal intercostal membrane, which we would normally say was the superior costo-transverse ligament, but in this slice, it probably isn't. But you've got a nice view of the pleura. So if you want to do your paravertebral block, all you need to do is to bring your needle from the lateral aspect of the probe and come down towards this point over here. Inject local anesthetic, see the pleura drop, and then advance your needle ever so slightly into the space. And the reason I didn't used to advocate this technique beforehand is, in theory, there's a potential for you to direct your needle into that shadow zone, so you don't really know what's happening to the anterior tip of your needle. But actually, you don't need to go that far. If you get your needle about here, so you pierce through this muscle, this would be, and just to appreciate, this is the MTP block, but with a transverse view. So that's the midpoint between the transverse process and the pleura. So I think every time I do a paravertebral block, I'm doing an MTP block on the way. So I initially stop with my needle there, inject local anesthetic, make sure my needle tip is not further than I think. I see the pleura drop down, then advance in that space, and I don't go any further than that. This is quite a satisfying way to visualize access because you've got a large surface area over which you see the pleura drop. And when you know you're in the right place, the patient will often make a noise. They'll groan, they'll make some noise, and that's often suggestive that you're in the right place. If it's completely pain-free for somebody, I would suggest you're probably not in the paravertebral space because that peeling away of the pleura from the anterolateral surface of the vertebral body feels a little bit uncomfortable. But I use this technique in patients who, as I said, are a little bit more cuddly because you can use it lends itself very nicely to a curved array probe, but it's actually ergonomically quite nice to do. You get somebody in one stable position, you can bring a needle in plane. I find it a lot easier than trying to, if you just hit freeze for me again, please. I find it a lot easier with a curvilinear and transverse in plane as opposed to doing the block like this. Because in patients who are a little bit cuddly in that orientation, you'll often get an image that looks something like this. Even with maximizing it, you don't see the pleura that well, whereas when you turn around in the transverse view, suddenly that process becomes a little bit easier.